Welcome to AETCM. Today's case is about a 49-year-old female, known case of type 2 diabetes mellitus, bronchial asthma, who is a homemaker, presented with complaints of cough, fever, and worsening of shortness of breath since 5 days. Cough was productive in nature with copious amount of yellow purulent sputum, non-foul smelling with postural variation, more on lying down. Dyspnea on exertion was progressive in nature, MMRC grade 3, aggravated on lying down. No associated hemoptysis, chest pain, palpitation, loss of weight, loss of appetite. She has history of recurrent episode of infection and hospitalization since last 2 years. No travel or contact history. Past history. History of bronchial asthma. She is on inhaler since childhood. History of ABPA 3 years back. Type 2 diabetes mellitus on OHA. Family history. History of OAD in mother. Born out of non-consanguineous marriage. Has 2 children. Personal history, no history of smoking, no exposure to biomass fuel or pet animals. Immunization history, she is unimmunized. General examination, she is
Tell me the differential diagnosis at present. You already told it.
It can either be bronchial asthma exacerbation, infective exacerbation, or some complication of...
Bronchial asthma is infective or inflammatory exacerbation?
Inflammatory.
Normally it is not infective. Very rarely you get infective exacerbation. It is actually inflammatory. Bronchiectasis, what is the reason?
She has past history of ABPA.
ABPA.
Yeah, allergic bronchopulmonary asthma.
Okay.
So bronchiectasis is a possibility.
Okay.
And also she is complaining of copious amount of
sputum. Any postural variation?
Yeah, postural variation on lying down.
Okay.
More productive.
Okay.
So that also.
You suspect TB in this patient? When will you suspect TB in India? As a respiratory doctor?
When they complain of there is in immunocompromised patient, there is loss of weight, hemoptysis.
So usually there should be an evening rise of temperature, prolonged duration, chronic cause of cough.
Cough more than 2 weeks itself, we have to suspect tuberculosis. That is one of the common problem in India. Okay, so we have to suspect. That doesn't mean that it is tuberculosis. Okay, will you suspect a fungal infection in this patient?
Yeah, she is diabetic.
Okay. Okay. So these are differential diagnoses. When you are evaluating, we have to see all these things. Okay.
General examination, she is conscious oriented, poorly nourished. She has grade 2 clubbing, no pallor, icterus, cyanosis, lymphadenopathy. JVP is not elevated. Pulse rate is 97 per minute. Respiratory rate 30, abdominothoracic. BP 110/60, right upper limb, sitting position.
What is this abdominothoracic respiration?
Due to accessory, since she is using accessory muscles of respiration.
Normal respiration is what? Thoracic abdomen. Okay.
Saturation is 78% room air and maintaining 92% in 4-liter oxygen.
Is she taking home oxygen therapy?
No. After this admission, we started.
Okay.
ABC. Head to toe examination appears to be normal. Respiratory system, upper respiratory tract, nasal septum appears to be normal. Nasal mucosa, nasal polyp present. No paranasal tenderness. Good oral hygiene. No tonsillar enlargement. Lower respiratory tract, shape of chest bilaterally symmetrical. No drooping of shoulder. Trachea appears to be central. Apical impulse not visible. Chest wall movement appears to be normal on both sides. Abdominothoracic respiration. No visible pulsations or dilated veins. There is use of accessory muscles of respiration.
What are the accessory muscles?
Sternocleidomastoid, intercostal muscles.
Externally intercostal muscles, scalene.
Okay, muscle of respiration.
Right.
Is it used for muscle of respiration is used in inspiration or expiration?
Active inspiration. Palpitation, no local rise of temperature or tenderness. Trachea palpated to be central. Apex beat palpable at left fifth intercostal space, 1 cm medial to mid-clavicular line. Chest movement bilaterally equal in all areas. Chest circumference 70 cm. Expansion 3 cm, 1.5 cm on each hemithorax. Spinoscapular distance equal bilaterally. AP diameter 17 centimeter, transverse is 32. AP to transverse ratio is 0.63. Tactile and vocal parameters equal on both sides in all areas. Percussion, resonant, not heard, bilateral on all areas.
Is it equal, or how do you express that tactile vocal parameters? Equal or resonant, hyper resonant, dull? That is a terminology to be used. Yeah. It can be normal.
And resonant.
Okay.
Auscultation, bilateral coarse crepitations are present. Bilateral V is also present. Other systems are within normal.
You tell the crepitations you are told.
Of course.
You tell in detail. Inspiration, expiration, and inspiration. Coarse, wet, dry. After cough, what will happen? After position, what will happen?
It is mid.
You tell. You are respiratory specialist. For emergency medicine, crepitations are enough. That is enough. But for you, it has to be complete. You tell inspiration, expiration, what happens after cough, after position change, what happens. Everything is important.
After position change, it increases crepitations.
After cough?
After cough, decreases.
Is that important or not?
Yeah, yes, sir. Clearing of.
Because most of the time, when you see crepitation in emergency room, it is mostly because of the airway secretions. If you cough it, sometimes it will be completely cleared. That's why these things are important. Okay. Bilaterally diffuse crepitation means if I hear your history, this patient is having bilateral pneumonia or bilateral ARDS, something like that, it will come to my mind. But if it changes after cough or after the change in position, then it is something else. That is very important. Okay.
Then we took an ABG which showed respiratory acidosis, type 2 respiratory failure.
What is the pH?
7.271.
Okay.
PCO2 was 96.
Compensated or partially compensated? Not compensated at all?
No.
Is that important or not?
Yes, it is important.
Why it is important? In asthma, what will happen to the ABG values? What type of respiratory failure you get in asthma? You tell me.
Type 1.
Type 1. Okay. Will it be compensated?
Non-compensated.
Hypoxia means what? It will not produce any acid-base disorder. Then later it will become hypoxia with hypercarbia. Later it will become acidosis. Later it will become compensated. It takes longer time. Within 24 hours only that compensation starts. So normally in asthma there will not be any major change in the acidosis or something like that. If there is a chronic problem, then you have to suspect like acidosis, compensation, all these things are there or not. You have to check. Is it like that or it's an acute problem?
Now he is having an infection.
No, I am asking the ABG only. Is it ABG shows only acidosis or acidosis with partial compensation, full compensation?
Bicarbonate is 42.
42 is high, no? So
Yes, it's compensated.
pH values?
7.2, but not
7.2.
fully compensated.
So something else is there for acidosis? It is compensated. It's actually for your bicarbonate wise it is compensated.
96.
But pH is only
7.27.
96. Oh, okay. So it is acute on chronic. Okay.
Then
After ABG, what else you did?
we'll do chest X-ray.
What is the chest X-ray finding?
Chest X-ray we can see like dilated bronchioles.
How can you see dilated bronchioles in chest
Traction.
X-ray? Traction. Tell what is it in the chest X-ray? Right side, left side, upper lobe, lower lobe. Is that important? Upper lobe bronchiectasis, is it important?
The past maybe sequel of TB.
Middle lobe bronchiectasis,
That
lower
also.
lobe bronchiectasis, one side bronchiectasis.
Yes, it's important.
Is that important?
Yeah, congenital and acquired.
Tell all these things.
Yeah,
They all are important. For emergency medicine, nothing is important. If bronchiectasis is there, we will treat. But for you, it is important.
In acquired causes, it may be localized to one lobe or one side. For example, in TB, it is like mostly upper lobe is affected.
Okay, mostly it is not bronchiectasis. TB normally produces upper lobe fibrosis, middle lobe bronchiectasis.
Yeah, lymph nodes may be obstructed.
What is Brooks syndrome?
Yeah, middle lobe bronchiectasis following TB.
What is Gons focus?
TB, complex lymph node and
If you know, you tell, otherwise she'll tell.
Hypersensitivity.
Gons complex. What will happen?
Type
Lymph nodes will be enlarged. Okay. So that is very common in children, and later in the life I can see middle lobe bronchiectasis. Okay.
in congenital causes like cystic fibrosis.
Okay. Is it bilateral or unilateral?
Bilateral.
It is bilateral. Okay.
Then
ABPA, what type of bronchiectasis you get?
central bronchial.
Central lobar. Okay. It's also bilateral. Mostly they are bilateral.
Then acquired causes are recurrent infections, foreign
Pneumonias.
body obstruction.
Okay, foreign bodies, pneumonias. Okay.
Congenital maybe cystic fibrosis, alpha-1 antitrypsin deficiency. Then young syndrome, cartaginous syndrome,
Okay.
ciliary
Okay.
problem. Then yellow nail syndrome.
Okay. In this patient, what will you suspect? Your patient, what will you suspect?
Since she is having past history of ABPA, can
So
be
the possibility is ABP only.
Yeah.
Okay.
And then there is no history of infertility or anything, so
Okay.
not considered.
Now next is what? How do you manage? What other investigation you do? What management? First you have to do some management. No? You have to manage the case first.
Yeah,
So basically you have done an ABG and a chest X-ray. That's more than enough to start the treatment. How do you treat this patient?
First we can give like oxygen is already kept.
How do you give oxygen? Tell me, how do you give oxygen for this patient? You tell, even if it is wrong, no problem. But you have to tell now. How do you start oxygen? She is having 90% CO2.
With 4 liters she is maintaining.
She is maintaining. So what will you do now? She is on 4 liters of oxygen, but saturation is not improving. ABG still shows very low pH. CO2 is very high. What do you do?
changing to 9.
And maybe
NIV. We have NIV, but immediately start on. If there is no pneumothorax, patient's consciousness is good. NIV is better than anything else. So you start on NIV. Okay, so that can be done.
Then
Okay.
you can give nebulizations.
What nebulization?
Salbutamol.
Salbutamol can be done. Okay.
Up to 3 cycles, 20 minutes apart. we can
Okay.
give.
What will you monitor when you are giving salbutamol?
Potassium.
Potassium is very important when you are giving salbutamol.
Then mucolytics we can give.
Mucolytic, what will you give?
Then
They are giving every day.
Yeah.
Recombinant and all we are not using.
This N-acetyl
N-acetylcysteine. N-acetylcysteine nebulization can be given. If any other tablets are available, you give no? You give in your practice. What is?
Mucolytic.
There is brand name.
N-acetylcysteine.
N-acetylcysteine can be given otherwise. Give.
No, acebrophilin.
Then
Then chest physio and all.
chest physiotherapy can be given, but before that you need to take a CT and rule out bleeding tendency. Okay, hemoptysis should be ruled out. Okay.
An
Now,
antibiotic
what antibiotic you want to give?
which covers both the gram positive and gram negative.
No, you should tell properly one organism. That is what
The
is
Pseudomonas. For
Pseudomonas.
this patient,
Pseudomonas is the most important organism in bronchiectasis, so that has to be covered.
So this patient's sputum culture was positive for Pseudomonas.
So most of the time, this organism, Pseudomonas, will grow in cystic fibrosis, your bronchiectasis everywhere. So whenever patient admitted with infective exacerbation, you have to start anti-pseudomonal drug. What is the anti-pseudomonal drug in then?
Uh, the
Piperacillin
Piperacillin
tazobactam. Is it single
ceftriaxone.
drug therapy or multi-drug therapy? You have to tell all these things.
So the anti-pseudomonal we should not target with a single drug. We should always give two drugs.
Two drugs. One is piperacillin tazobactam. Other one is okay. You can give either quinolones, levofloxacin, moxifloxacin, or you can give tobramycin. Okay, so that has to be given. Okay, then
Then
next is what?
Nebulization, still.
Steroids cannot be given. That is a problem. We have to rule out fungus. Okay,
then on discharge you can give immunization after.
No. Next investigation, next set of investigation. You want the CBC, CRP, procalcitonin, sputum for
Culture, gram culture, fungal culture.
Fungus is very important. We have to check for fungus. Okay, then
AFP.
AFP should be done. Okay, that is very important.
Promote other syndromes like Katarina, eczema.
That should be done, but in emergency room we have to do one more test. What is that test? You might have done it. See, it's not that important. CT? CT has to be done. No? It's done. It's already done. You have to tell me the finding.
It shows it's diffuse cystic and varicoid bronchiectasis. Bilateral lungs.
Bilateral. Okay, so mostly it is due to ABP only. Okay, so any other immunoglobulin you have to check here?
IgE.
What is the IgE level? Is it high or normal?
That is high.
So we have to see whether it is in thousands or 10,000 like that. If it is very high, what do you do?
Well, then we can evaluate for ABP.
Right. It's mostly ABP only. Already it is diagnosed. If it is IgE is
and
monoclonal antibodies should be started. Okay. Can we give steroids?
No.
Initial phases, if these monoclonal antibodies we are not giving, we can give steroids, but sometimes it can produce adverse effects because it can flare up the infections. Okay. Should we rule out fungal infection in this?
Yes.
Okay. Normal fungus can grow inside this bronchiectasis and it can increase the destruction. So we have to rule out fungal infection also. Any fungal growth is there?
No, in this patient we did not get.
Okay. How will you discharge this patient? What are the treatment you advise for this patient?
We will discharge on antibiotics, then mucolytics.
Okay, what antibiotic you give? Tell me about chronic lung protective antibiotic therapy.
Maybe azithromycin.
Once you treat this patient properly, if you train him for lung toileting, that is like one side, patient has to be one side, draining has to be promoted. Then if the infection is completely treated, then you can start on azithromycin, 250 milligram alternative days continuously. What is the action of azithromycin? Is it given for as an antibiotic or something else? Anti-inflammatory. So it is basically given as an anti-inflammatory drug, but it also treats your infections. Okay, then
This
should we rule out tuberculosis in this? How do you rule out tuberculosis? What about Mantoux test in this patient? What is the role of Mantoux test in this patient? You are going to give an immunomodulator in this patient. So it's so if suppose it is Mantoux is positive, then what do you do? If it is Mantoux is positive, strongly positive, what do you do? Tell me about the prophylaxis. INH prophylaxis. You have to give. If it is strongly positive, you don't have proper evidence for tuberculosis, INH prophylaxis should be offered to the patient. Okay. Then vaccination.
Influvac and Prevenar we can get.
What is that?
Influvac is for influenza
B. Then
Prevenar for pneumococcal.
Pneumococcal.
Yeah. Once in 5 years.
Once in 5 years. Other one?
Yearly.
Okay.
Then since she is having
what is the diet you advise for this patient?
Protein
high protein diet. Why high protein diet?
Because sputum
contains large amount of proteins. Then how do you control his respiratory problem?
Inhalers we can.
Inhalers, what inhaler you advise?
Um,
What is,
combination of
what is an inhaler you advise?
combination of
Hmm? This patient is having ABPA. Then what will you do? Is it only salbutamol or salbutamol with steroid? Salmetrol or formoterol with steroid. It is not actually fungus. It is something like fungus, but it is an immune-mediated problem. Steroids may be helpful in this patient.
anti-inflammatory.
Okay. Then
Then home BiPAP and LTOT.
LTOT. What is LTOT?
We give 1 to 2 liters of oxygen for 16 hours per
Okay.
day.
Is there any pulmonary hypertension echo is done?
Yeah, because now it is not.
It is not there. Okay. Will oxygen therapy prevent pulmonary hypertension? LTOT is given for what?
Yeah.
So it is given to prevent pulmonary hypertension. Okay. Anything else you want to tell? Anything else you want to tell? Or what did you understand now? Tell me, what did you understand this 10 minutes? What all things you learned? You can tell. Tell fast. You have to tell.
A patient presented with respiratory distress and cough and productive. We should think about the differential diagnosis like TB, exacerbation, inflammatory exacerbation of asthma, or we also look for any.
So how do you manage the case in emergency room? That is the first thing. Patient come with the respiratory distress to ER. What will you do? What should be the position of patient? Propped up. That is the first thing. Second thing, start oxygen. If oxygen is not working, put him on NIV. Third one is nebulization. Here we are giving salbutamol nebulization, but we normally give salbutamol with ipratropium bromide combination. Then when will you stop oxygen? You are giving 5 liters, 6 liters oxygen to this patient. And now you know that this patient is having chronic lung disease which is producing very high carbon dioxide for a longer time. Now when will you reduce your oxygen? What will you do with your oxygen therapy? You are giving high flow oxygen, 100% high flow oxygen initially. What is the immediate step you have to do once it is corrected? If you don't correct, what will happen?
Type 2.
What is this respiratory drive? They are telling respiratory drive.
And there will be more CO2 washout and the drive for the respiratory centers.
Okay. So if you give more oxygen, carbon dioxide will be washed out. Then later there will not be any drive. Patient go to respiratory arrest. This is a common problem occurring in every ward. Okay, we give oxygen, we forget it, and patient go to respiratory arrest. So that should be avoided. Only 2 liters oxygen will be enough in this type of patients. Okay, thank you.